Tonight, welcome to this public hearing on healthcare in Arizona. This is an event put on by Arizona Indivisible CD6, but we've had plenty of help from our sister organization, Desert Progressives, and also Indivisible Phoenix, Stronger Together Arizona, and especially Indivisible Surprise, which put on a first iteration of this discussion about a month ago. I should utter a sentence I don't think I've ever uttered in my life. If you have a cell phone, could you please silence it? It's my new life. Right? Listen, on your way in, you should have received an index card. Did you? Great. Okay. Fantastic. So, step one. You're welcome to use these index cards right now or over the course of our event in order to put to our panel a question about healthcare in Arizona. If you'd like to do that, and we hope all of you will, please just pass it toward one of these two center aisles here. And if the person on the end can sort of wave it when they get it, it will be picked up by Noah, who's back there, or his mom, Karen. Did I embarrass you, Noah, by saying that? Karen, who's around. They're going to be collecting these cards, and they're going to deliver them back here to our friends Erin Gilly and Liz McCooley. And we want to hear from everybody. We're not doing any kind of screening or anything like that, but I'll be reading those cards to our panelists. But there is one thing I did want to say. Because we want to cover as many areas as possible, and because we don't want to get mired in one place and avoid redundancy, Liz and Erin are looking through to make sure that we don't get redundant or become mired. Okay, so that was just something I wanted to explain. Anytime you have a question, please write it and hand it out. And you didn't get it. Oh, perhaps Liz, you could provide an index card for our member here in front, okay, or anyone who can. Okay, so down to business. So as I think we all know, your presence here implies that you're very aware of this fact. Though a few weeks ago, the House Republican plan to repeal the Affordable Care Act sank, failed, right, imploded. Republicans in the House have announced in major media that they remain determined to repeal the Affordable Care Act. And so healthcare remains this very live issue for us. And yet, over the course of this entire season of calls to repeal this law that has been in place now since the beginning of the Obama presidency, what has been missing has been a public hearing with experts. The kind of thing that usually holds so that lawmakers can write really good, sound, strong legislation. So that's where we got the idea for this event. We think that hearings with experts are important. Experts are important. They teach us all kinds of things, and they teach our lawmakers all kinds of things. So with an eye toward sort of promoting that kind of level of public discourse, we assembled this panel of willing experts, and we also invited every member of the Arizona Congressional delegation and every member of the Arizona legislature's Committee on Health and Human Services. I'm very sorry to say none of them are here. I'm especially sorry to point out to you that the congressman who represents the district we're now sitting in, Congressional District 6, Congressman David Schweikert, is not here. He was invited a month ago. His district director confirmed with me that they received the invitation. But the special reason why I regret that is because just last week, Congressman Schweikert introduced some language for an amendment that would help to sort of restart the repeal effort. For that reason, I'd hoped that Congressman Schweikert might be here tonight. And even though he is not, we are live streaming this to Zoom. Later on, we will have a video of this on YouTube, and so we will be able to sort of let the congressman know what kind of discussion we had here tonight. So without further ado, what I'd like to sort of do now is to introduce our panel, after which I'm going to ask them to start us off by saying a few words. And then after that happens, we'll start the evening of questions for our panel. So directly here to my left, to the right, where you're sitting, is Michael Boylan, who is Chief Executive Officer for Crisis Preparation and Recovery. And that's a network of behavioral and mental health providers that serve thousands here at Phoenix. He's been providing crisis intervention services in many capacities for the past 16 years, having started his career as a crisis counselor in a New York City public elementary school, but having moved to Arizona in 1994, working for the countywide mental health crisis system, and later serving as Director of Crisis and Referral Services under Value Options until 2001, when he began with Health Crisis. Next to Michael, let me introduce to you Saman Kasim. Saman is Director of Health Policy for the Children's Action Alliance of Maricopa County. She has also been an administrator for the Office of School Health and Wellness Initiatives for the Maricopa County Department of Public Health, and is an extremely experienced administrator of community health programs who has worked on international policy analysis in Washington, D.C., and has also served as a Director of Health and Safety in Nassau, Bahamas. On the other table here, going right down the list, we are honored to have with us Mike Rosa, who's a Senior Director from Aurora Behavioral Health System and who has 30 years of experience in healthcare at both the administrative and the clinical levels. He is an expert in acute, primary, long-term, and behavioral healthcare, as well as operations, community organization, integrated healthcare, and quality improvement, and he is especially learned in the challenges we face as a state concerning rural healthcare. And then finally, last and very, very not least, I'd like to introduce you to Dr. Denise Link, who is Governmental Affairs Officer for the Arizona Nurses Association and co-chair of Practice Committee for the Arizona Action Coalition. She's also an educator in nursing, by the way, and a practicing women's health nurse practitioner since 1979. She is a fellow of the American Academy of Nursing and the American Association of Nurse Practitioners, who holds many other positions in healthcare and nursing at the state and national levels. And she's also department editor for the Journal of Nurse Practitioners and is involved in a number of legislative initiatives for nursing and health-related issues in New Jersey and Arizona. Welcome, Dr. Link. And could I just ask for a round of applause to welcome Dr. Link. So as I say, as questions occur to you, please do write them on those cards, pass them to the center aisles. Noah and Karen will be right on that, and we'll get them up here. But in order to sort of start us off, I have a very basic question I'd like to put to the panel, and anyone who would like to chime in on this, I'd like to hear it. As I pointed out, Republicans in Congress remain fixated on repealing the Affordable Care Act. Now, many of us here are made anxious by that prospect. But on the other hand, if everything were okay with the ACA, we probably wouldn't be here tonight. Right? So I wonder if one of you could please tell us, what is the Affordable Care Act? What has it accomplished? Should it be repealed? If not, where might it be reformed? Oh, and sorry, you all have you all have microphones there, which should be on. Looks like should be on already.
Thank you. That, as my facial expression gave away, it's a pretty huge question. But the Affordable Care Act was intended to try to do something about the financing, really. It isn't really necessarily financing reform. And how do we pay for health care and do it in an effective way? And how do we efficiently use what healthcare resources that are available to us and try to shift the attention away from the high-tech, high-cost care that typically people access late in the process of an illness or a condition, and try to encourage the system to move people to more health promotion and prevention sort of mindset. Change the thinking about healthcare from an illness focus, like I only go to see a healthcare professional to how can I become healthy and stay healthy to reach my fullest potential of my health. And that's all I can think of. Did somebody else want to talk about particulars? And to that end, keeping people covered till they're 26, making sure that people with pre-existing conditions aren't cut out of the health system. Maybe I need to hold the microphone a little bit closer. Is that better? I'm sorry. I can hear myself. Yeah. I would like to do that. So I'm so glad you opened with the part that most people don't think about, which is bending the cost curve. And the reason why the ACA even went into law to begin with is because healthcare is
very expensive in America, and it's not getting us the same results as other countries that spend as much or less. So that is bending the cost curve with an emphasis on prevention by changing the way we pay for it. So instead of every MRI, a provider can bill us. No, you can bill us for bundled payments. Someone gets better, and then we'll pay you for that. And then the piece that's so covered widely, and that the GOP talks about a lot, which is the marketplaces. So increasing the number of insured people is a way to get more people into preventative care versus the high-end care at the ER. And so the establishment of the marketplace, or the ACA marketplace, and that's really what people think of as Obamacare. And then the insurance regulations, which really help everyone on health insurance, not just in the marketplaces, but also with employer-sponsored insurance, and then expanded public insurance to working people, so with Medicaid expansion. Oh, here.
I think hello, my name is Michael Boylan, and one of the other big successes, I think, of the Affordable Care Act really relates to patient protections as well. It's really a key driver that no longer can insurance companies drop people because they have a certain diagnosis or they've met a certain cap and they've used X number of dollars of insurance. And so that was a big piece of the Affordable Care Act that I think we all need to continue to remind ourselves about, that there's a lot of patient protections related to us as individual citizens that are have a right to health care, and that we can't be kind of pushed around by the insurance companies because we get a cancer diagnosis or we get a chronic disease that they don't want to pay for anymore. So that was a big part of the Affordable Care Act that has been truly beneficial in my experiences. And the other big part really on the behavioral health side is that there are really some key essential health insurance benefits that every plan has to cover. One of those being behavioral health, that insurance companies could not discriminate against individuals because of a mental health issue, and have coverage, and are folks that are now willing to seek out care early on in a particular diagnosis when we start to recognize symptoms of either bipolar illness or depression or stress in their lives, that they really have some resources that historically were out of favor prior to the Affordable Care Act. So mental health has been a big winner with the Affordable Care Act, especially around those protections. In addition to Medicaid expansion, I mentioned at the surprise forum that I was invited to, that one of the things we all need to kind of celebrate is Governor Brewer, and for her willingness to kind of step out and kind of go against her party and be willing to put her name on the line and expand Medicaid in the state of Arizona. It has been great for our citizens, been great for the working poor. It has been fantastic for the healthcare community. We've seen just tremendous number of jobs in the state of Arizona that other places in the country are coming, looking at us saying, we want to kind of emulate what Arizona is doing, because we really have built a very robust system, not only in the Phoenix and Tucson markets, but our rural health is improving. It needs to get better, of course, and I'm hopeful that we can continue to find ways to push for some of the modest changes that need to occur with the Affordable Care Act. And I think we can talk about some of those solutions later tonight.
And also I work in the behavioral health field, and my background is very, very varied. And Mike and I are both social workers by degree, and I came from Reno, Nevada in 1999 to Tucson, and I worked for United Healthcare in the API-PA system as a UM manager for all of the patients outside of the Maricopa County. So all the hospitals in Yuma, Tucson, Kingman, Flag, I was the manager, and we had 100,000 lives that we managed with a medical team of 10 nurses, a medical director, and myself. And what I found is in the rural communities, we had care near the hospital. But as soon as you went 20 miles out, if somebody needed an MRI or an X-ray or was getting cancer treatment or chemo or something like that, it put a great hardship because sometimes transportation was an issue, just depending where you were at. And then we got into the reservations and also with the nations is how we take care of our Native American populations. Now you see the Medicaid system become part of the nations. It is part of their system now that they can access also. I was very happy to see a Medicaid system, as Mike said, as robust as access is in Arizona. I came from Nevada. Nevada's Medicaid system couldn't even compare to what Arizona's is. Arizona's is a managed care system. A lot of state systems are still run by the state government. And there's a whole different mentality on the way treatment is completed, and eligibility and age groups can be highly affected, especially with children and especially with the geriatric population of 65 plus. Behavioral health, again, I'm proud to be in Arizona now because Access does an excellent job of behavioral health care. In Nevada, I worked at the state hospital when I first started in my career, and the philosophy there is if the legislature was getting low on money was to discharge the patients away from the inpatient setting. And these are chronic schizophrenias, chronic patients who required the care of an inpatient setting, and we would let them go back into the community. And then usually what would happen, we'd have an incident in the community with a tourist or a citizen in the community, and that would push the legislature to put it all back in. And what I'm trying to get at here is there's an evolutionary process. I think our last talk, I kind of got up and tried to do the Bo Diddley, and I was like, who knows Bo Diddley? And we're all from that age group, and then right around the same time, the Beatles came. And that's when we started talking about, well, Medicare started in 1966, is when Medicare started. So if you look at healthcare and health plans and health systems, the evolutionary process has only been the last 40 to 45 years. And now we've got something completely new. And I don't know if you guys remember when the Bill Clinton was in office, it took them years to figure out how they were going to move forward. And Obama just happened to come into office and was carrying forward a lot of Clinton's work from the democratic process to put the ACA into effect. And in Arizona, I think you'll see either the research or even the materials is that we're trying to change something that it didn't let evolve yet. The evolutionary process has just started, and we're all sitting here now like, what do we do? You know, we've got our new president trying to make changes, whatever he thinks is best, but are we listening to our citizens? And I think that's why we're here tonight. Are we advocating for ourselves? And that's why we are here, is we got to get behind the 8 ball now instead of like a lot of times with social policy, we're too late sometimes, especially with children's programs and geriatric programs and everything in between. And everybody's brought up here, you'll hear things like value-based. And again, we've gone to a value-based system, and that doctor's practices now, if you go in, you'll notice they'll ask you about depression, they'll ask you about smoking, they'll ask you about your alcohol habits, they'll ask you, have you had a flu shot? And there's a reason they ask a lot of these, and there's some fancy words like HEDIS and preventative care that the nurses know better than myself, being a social worker. But I know we want to get those things done because those do cost savings at the other end. But that doctor's practice doesn't ask those questions, and the insurance company processes those. We will actually take money away from that doctor's fees for not doing it. That's what value base is all about. There is a lot of waste in our system. Us who work in healthcare, we get a lot of journals, we read a lot of internet materials, and there's millions of dollars that are wasted. And you'll see things on Medicare and Medicaid waste that companies require. Mercy Maricopa requires our company to sit through training on Medicare and Medicaid waste because there's so much waste and utilization. I'm taking a lot of time right now, so I'm going to move the phone.
Mike, can I actually, I'd like to ask more about that, especially getting back to Dr. Blank's earlier comments about the ACA changing the emphasis in this country from sort of getting all your care in an emergency room versus getting preventative care. And I think one issue that we've all heard about, many of us have lived with, is the issue of being a person with a pre-existing condition. Now, my understanding of the ACA is that prior to the ACA, you had a pre-existing condition, and you want to get personal health insurance, get out your checkbook. It's going to probably be prohibitively expensive. But the ACA covers such, and here I am talking to four experts that probably, the head is spinning at how crude a rendition this is. But the ACA covers such individuals by mandating coverage, right? By requiring individuals who don't have pre-existing conditions to get coverage, and that way expanding the pool so the costs are shared. Now, this gives some people hives. A lot of people think that's an overreach for government. There are some proposals on the table right now from mainly Republican members of Congress on alternative ways to fund people with pre-existing conditions. I wonder if anyone on the panel cares to address any of those. I know one in particular I'd love to talk about tonight, but our own Congressman Schweikert has, as I mentioned earlier, has an amendment on the table to the American Health Care Act, the AHCA, and that's the repeal bill from the Republican Party. And at the centerpiece of that amendment is something called a high-risk pool. Could someone talk about what is that and how does it work?
Thank you. Very, very simply, you just take all the people who have high risk, high care conditions and put them all in the same program, which I guess I'm not exactly sure what the rationale for that is, because then in my experience, what that results in then is a very, very expensive product that someone is trying to sell, and probably will have very few people who would participate or be able to. They would probably love to if they could afford it, and rather than, because they have to make decisions about what they're going to spend their money on, they'll say, well, I'm going to take a chance that I'm not going to get sick, and then if I do get sick, then I'll just go to the hospital.
Get your coverage by going to the emergency room.
And that's not really coverage. That's accessing health care. And then what happens then, well, first of all, as I mentioned earlier, some of those conditions could be avoided if the person did have affordable access to health care, and may be able to prevent them from having to access the emergency room. And we do know that's a fact, that people have access to comprehensive, regular health care, and not only having someone caring for them, but learning how to care for themselves in between visits is really mission critical. And then what does happen if the uninsured person comes to the emergency department, someone's going to pay for that. And it's typically the people who have the insurance. Those costs are passed on to the insured, people who use that facility, or it's passed on to the taxpayers in terms of making up the cost of uncompensated care. So we pay for it anyway.
So part of the point of the ACA was to stabilize rising insurance costs.
Yeah.
Has it?
On that note, when I worked at APIPA, that was part of, we had at that time, I believe there were 6 or 7 health plans in the state, Phoenix Health Plan, APIPA, choices out there. And what we learned is you got the bell curve, you have the outlier. And what you want to make sure is you don't load a health plan with all the high-risk clients, because it destroys the health plan. It also takes away from the care of the clients in the middle of the curve. And that's what I learned in that system, is that we have the outliers, people never get sick, but then we have the chronic illnesses that we're going to be taken care of in a long-term care setting for life that were high-cost items. And again, in our society, we've made a commitment to care for just about anybody. And again, it just came up at our last doc when we were talking, even the undocumented, they cross our border and they become ill in one of our communities, we will take care of them. We don't turn anybody away. And I think that's part of our American culture, is that we don't like to see anybody in pain or hurting at any level, whether it be behavioral health levels, medical levels. And all you got to do is show a child to somebody in pain, and they'll have us on our knees, because I don't think the American culture, we've been raised a certain way with our value systems, our faith systems, that we don't tolerate pain real well when we see it. And we do, sometimes it will make us very disgusted in the way we do treat people, and sometimes the way we take care of our communities. Another point where we're at it is you'll see things now called the patient-centered medical homes. And that's a new philosophy coming out with also, I saw today, I knew about, they call them PCMHs, patient-centered medical homes, and that's where you go in and get all your care. I just worked for a system called Marana Healthcare down in Tucson before I came up to Phoenix, and we were a federal qualified health center. And you have those up here too. I think Adelante is one of them. There's Circle the City. Yeah, there's about 4 or 5 of them. I never knew those things were out there. They are a great system. And I learned so much. But what I learned was now everything's a one-stop shop. And we had WIC, we had maternity care, we had all the care in one setting. And they were getting federal funding and grants to build these beautiful complexes. We had 14 clinics in Tucson. We took care of 40,000 patients in primary care. And we were one of the smaller systems. El Rio is another one. They were like 90,000 in caseload, and we cared for about 5,000 behavioral health. And what I found was I had to go make quality rounds in the primary care doctors, and I found we were doing an exceptional job. We had dental, we had WIC, we had all the pre-screening materials. So now we were providing a level of care that had been kind of the experimental, and now we're waiting for the public sector to catch up with it. And again, that's what I kind of have seen in the last year and a half. And then there's a new thing I just saw today I was reading about called the medical community. And that's the next level from the PCMH model, which is individual within a practice. Now you're tying in the community, the hospitals, the urgent cares, the home health agencies, the nursing homes, and they're building that continuum of care. And again, everything's looking at cost savings. As you know now, if you get sick in a hospital on Medicare and you discharge prematurely and come back within 30 days, the hospital will not be paid. They will absorb the cost of that level of care that they did not provide for.
So then, just on that point also, just so I get this straight, so a high-risk pool then is a way of covering such individuals with pre-existing conditions by putting them in a separate pool, hence the name high risk, that what is paid for by the federal government through annual, Simone?
I'm not sure the funding source on that.
I think Mike has some intelligence stuff to say, but the one thing I'll say is the funding is key. And the Schweikert Amendment only proposed $15 billion to fund the basically like a reinsurance program. And
$15 billion over 9 years, I think.
Yeah, that's not adequate. So
can anyone say how inadequate do actuaries tend to say that is?
I don't, I don't know specifically. If you know.
I just want to comment on high-risk pools. I think they're terrible ideas. They don't work. There's not a system that I've studied where they have been effective. I think it is a cop-out, really, to be honest. I think it's a way to discriminate and put people that are sick into a small group and hope for the best kind of attitude. So I really, I think we really need a model where 330 million people are in the pool, and that's all of us.
That sounds like single payer.
Well, it isn't really a Medicare for all type model with some choice. I mean, there's got to be some choice and ways to deliver care in a more effective and efficient way with more home-based services, more technology programs that can help, certainly in the rural areas, get care delivered to those environments. But the folks that we work with that had those high-risk pools prior to the Affordable Care Act struggled tremendously. It was very limited response from their high-risk pool plan. I think they felt like they had individuals captive because they had chronic medical conditions. There were really limited protections with the program. And it was financially bankrupt because essentially we're putting folks with serious health conditions in a very narrow pool together to say, we hope that we have enough money that can kind of keep individuals alive long enough. But often what would end up happening is people would die. That was the outcome of those pools. So we really need to move to a model where 330 million people are in the pool, and we dictate the terms to the various health plans or health providers. We have fantastic health providers, whether it's, you know, the Banner system, the Honor system, the Abrazo system, Mayo. We have beautiful facilities here in Arizona. They've improved significantly, just you know, how they look and the therapeutic environment that people are receiving care in. What we need to do is really eliminate a lot of the administrative waste that occurs in our healthcare system that really no other Western economy in the world experiences. And we are looking at, I just came back from a healthcare conference up in Seattle. Conservatively, we spend $190 billion more a year for administering our healthcare. That means we're paying various plans and they're checking enrollments, and, you know, we're benefit managers that are all of our employers. If we had a system where we could all be part of the Medicare system and then be able to maybe pick plans that are beneficial to us based on some of our health-related matters or choice issues, I think it would put us in a position where we could really get to a point where we can eliminate a lot of the waste that we currently experience. And if you take the 190 billion, that's conservative. There's some estimates it's up around 750 billion a year. Take the 190 billion alone, and just took those dollars, we could insure every uninsured person in America today. So that's what I'm kind of pushing for. I think these risk pools are really, it's an easy cop out. I think they're terrible ideas, and buying across state lines, all that stuff is just garbage, in my opinion. So I think we just need to move to a system where we can dictate. The healthcare changes when we can push people, where we can have everyone paying into the system, and we can drive down costs, because 330 million people can do a lot as far as competitive pricing and building a better system.
I'm going to squeeze in one more before I start to get these cards from you all. But to talk further about this, President Trump has tweeted that the ACA is about to implode. Is it? What would that mean for, well, to hit the areas of your respective expertise: children's health, behavioral health, the professions, including nursing? If it is about to implode, what needs to be done?
So again, you know, they keep talking about the ACA, it's the marketplace, right? And so just to put it into perspective, this bill that was to get rid of this harmful, horrible, you know, ACA, and really talking about this marketplace, which covers in Arizona about 190,000 people signed up. And it's true, there are problems. Anyone and everyone in, you know, on both sides of the aisle will admit that there need to be some fixes to the marketplace. But the bill proposed so much more than just repealing the marketplace. For example, repealing Medicaid expansion, which provided health care to working Arizonans, and to the tune of $425,000. The entire Medicaid program was going to be cut, basically. They call it, you know, block grant, per capita cap. It means cuts, it means rationing care. It's almost like putting people in a high-risk pool. That's 2 million Arizonans, right? Rolling back some of those protections, like when they said they were going to take away the essential health benefits, that's essentially taking away protections for people with pre-existing conditions. It doesn't directly get at that policy, but it essentially removes that. There are 2.8 million Arizonans who have a pre-existing condition. So they talk about the failures in choice and premium increases in the marketplace, which covers 4% of Arizonans, with a piece of legislation that impacts at least 2 million Arizonans. So that's a little bit of trickery there. And in terms of the Arizona marketplace, you know, Trump tweeted about how, you know, we had over 116% increases in the premiums in the marketplace. Arizona also has the lowest premiums in the country. In fact, so many before the years before, some people couldn't even receive all of the cost sharing because the premiums and the insurance was so cheap. They were like, you can actually afford this. So that's another part of the story. Definitely, choice and increases for premiums, especially people that work what you'd say like maybe above low income at the 250% of the poverty line. There are problems there. But I think the bill, it was kind of like, what is that expression when you're like trying to fill in a mosquito with a hammer or something? It just, yeah.
Can I just cut in? Is that like, the problems that we've seen, spiraling costs and reduction in terms of choice, are those outcomes, in the opinion of the panel, endemic to the ACA as it was originally written, or is there a history to this? Whose fault? And can it be fixed? I flummoxed the panel.
I think that the big piece is, and I talk to my colleagues at work, the big piece, as far as I'm concerned, that we allowed the insurance companies to kind of get into the exchanges to provide coverage for individuals that are either not eligible through Medicaid, children that are not eligible for kids care, or they're not working for an employer group that's either large enough or can offer the health insurance benefit. So we have the problem with the exchanges really comes down to the issue of we're left with a smaller group of people that really need health insurance because they're signing up for it and they have some chronic health conditions, but the number of people in that category is too small to really ensure that the savings for those plans are efficient and make sense. And so a lot of plans just with that small set of individuals could not make a business case for why they should continue offering a health plan on the exchange. One of the pieces that Gary Moore, who's here, and Mark Lee from CPR, that we talk about all the time is that we have really a pretty successful Medicaid system that operates throughout the entire state. We have numerous plans that are providing health coverage through the Medicaid system. And so one of the suggestions that we have made is that the individuals that would be eligible for the exchanges could sign up for health insurance through our delivery system on the Medicaid side and pay based on their income levels into the system. And so it would force force those health plans who don't want to give up the Medicaid business to have to provide care through the affordable exchanges throughout the entire state. We would have instant competition. We'd have health plans throughout the entire, all the counties in the state. And we would link the Medicaid business to the exchange business so it would not be in their business interest to leave. And that would be one way in the short term, until we maybe can get to a Medicare for all. That would one way in the short term that we can really offer significant savings on the exchanges by bringing that group, 400,000 people that get coverage through the exchange, put them in with the 2 million people that are getting benefits through Medicaid, and now all of a sudden we have 2.2 million people in a pool rather than 200,000 in a pool. And so that's been the problem with the current model.
Yeah, I would like to piggyback on that. First of all, I'd just like to say myself that it's hard for me to feel sorry for the insurance companies when they're making record profits, and that is a fact. That is an evidence-based fact. But be that as it may, let's just make that assumption that they're really taking it back in the marketplace. Then I think that is a perfectly reasonable suggestion to make, to then make being in the marketplace more attractive to them. Because one of the questions that you asked in preparation for this was, what would, if I had one thing that I could fix about the Affordable Care Act, what would I do? And that's what I said, fix the risk pool problem, because that's exactly where the problem is. But the other thing is too, I would like to really just, if I was in charge for a day, I'd just like to call their bluff. Oh, you don't want to be involved in healthcare anymore, you insurance companies? Good, we'll just turn this over to the government. You guys will do something else.
Well, I don't know which is worse, the pharmacies, the pharmaceuticals, or the insurance companies. Because what you're seeing now is you kind of keep a pulse on the insurance, you'll see them, what we read on our internets and our newspapers is we've got kind of the big five now: Humana, Aetna, United, Blue Cross Blue Shield, Cigna. And I think there's a couple of those are trying to merge, but they were kicked out of that last year. And again, so why are they trying to merge? And again, there's like this covert undertone to an insurance company. Again, I work for insurance companies. I understand the claims process. And again, it's scary sometimes when you look at, well, you can only be in the hospital for now 1.5 days with a hip fracture. It used to be a week. And again, the value base, if you go home and come back because of complications, that hospital is going to be eating the bill on that, which I think is justice for the system. And again, if you look at hospitals, there's a change in hospital systems. They're realizing now that a good example is Aetna Banner. Huge provider network now, and you're getting away from the med surge component as much. Now they'll close down wings, and depending on the season, they'll come back and open the wing up and use staffing agencies to come in and staff those units with RNs and the medical staff to take care of the patients. Goes down, they close it down. And if you notice, they're buying up the medical practices. And the doctors are smart, and they're either going to deal with Medicaid in some states, again, Nevada is one of them. A lot of doctors won't deal with Medicaid because you're doing discount work. They're saying, why should I discount my services, Mike? You're paying full price. Why should I make it a less price for a Medicaid client who may require more service? So you've got this injustice in the system, and again, there's mentality. There's a Medicare mentality, and then there's a Medicaid mentality. And Medicaid was set up for a reason. It is usually financial eligibility to get onto a Medicaid system. Medicare is an entitlement. You're entitled to Medicare if you paid in your quarters. I think it's 10 years, 40 quarters. If you pay in your quarters, you are entitled to that, just like a veteran's benefit. If you're a veteran, you are entitled to benefits. We're all entitled. We have disability. Again, I see a lot of disability under age 65 in the mental health arena. You'll see people 30 and 40 years old who are working in society that became disabled due to a mental illness. And again, that is an entitlement. And I think that's what I'm seeing kind of mixed up here. I think, as I was driving here tonight, I was saying, what would we do with all the money that we pull into our healthcare system? And Diane and I were talking about that real quick. It's like, well, we would put it into military spending, and we did put it into healthcare. Where would we put it? And again, growing up as a kid, I used to see all the ads, UNICEF, Feed the Kids in Africa. We had a lot of money being donated out to help people. And again, they went kind of for our throats of the children, showing the starving children. But again, when you sit in this room, there's populations, and all of us at times I feel like being kind of taken advantage of by the bureaucracy of Washington. And it's kind of sad because we elect these officials, and then it doesn't seem to work to our benefit. And again, I believe in majority rules. That's kind of the American way. We go with that, but then there's what is kind of reasonable and what is a responsible decision for the health care of somebody.
You said, did you know that healthcare was complicated? I have an intriguing question for the audience, and I just want to also note, since you bring it up again, Michael, all of your representatives were invited tonight. They aren't here. But the audience member asks, and maybe it's above your pay grade, but you'll let me know. Who really is writing legislation that would replace the ACA? Really is underlined. I think the implication is that there are lobbying groups, that there are interest groups involved with this process.
I just have one comment. I mean, there's a process, and they meet with experts and all that. But I forgot to mention that the bill, the repeal bill, had a significant tax break for people. So just put two and two together. Tax break cuts to federal cuts in care to states.
I think that came up in the thanks. That came up in our last conversation about a month ago. Is that and again, I think we watch TV and we see the big here's the Healthcare Act and the paper stack this high that nobody could ever read in a lifetime. And then, of course, they're very sneaky about putting things in there covertly that kind of helps out their area of the state or county where they live at. But it's not always for the whole person or for the whole people of the United States. There tend to be favored pockets depending on who has control and who's on what committee. And again, it gets into the politics of who are we taking care of? And again, the people in this room, I think we're here tonight because we want to take care of us as individuals, but then again, we do care about the children. We do care about the seniors in nursing facilities. We do care about people that may be dying from a chronic illness. And we're here to help people. And again, healthcare is all about helping. You know, sometimes I think we lose our focus of how we help because we get bottom line oriented. And again, I think we've all had to look at our bottom line because you can't do business with a lot of red in your ink. It doesn't work that way. And doctors and behavioral health people are that way. And nurses, I know, came from that mentality, just like social workers, like they want to help. And it can't be therapeutic, and it can't be medically oriented. You want to help the best you can at any level.
Another audience member asks, I'm going to get through as many as possible. You could talk more about essential benefits and how you've seen essential benefits. I believe there are 10 associated with the Affordable Care Act, affecting the lives of patients and the actual people, clients, people that you've worked with. And just to clarify, this is an honest question. I don't know this. The AHCA eliminates some of those benefits, all of them.
There was an amendment later, I think, right?
Okay, forgive me. I should have.
Yeah, there was a proposal on the floor to bring the people who were in the the Freedom Caucus. That was, well, you know, that's what they call themselves. That's fine. But that was how they were trying to persuade the representatives in that group to go along with and support the American Health Care Act, because those folks were of a mind that with all of the things that were being rolled back in the Affordable Care Act was not going far enough. They really objected to these essential health care benefits. And that's where, you know, I wanted to make a comment back on something you said very early in our conversation about that, and even now it's about, you know, the desire to do good. I think that the fact that many of you are here, you would probably agree with that statement, that at least most of the people, if not all of us in this room, that's our driving force. But I think the fact that there were comments being made during the deliberations over the American Health Care Act, where things being said like, well, I don't have to have this kind of health care, so why should I pay for that for someone else? And to me, that was very, very disturbing. So I think that while I certainly feel that I'm, you know, the keeper of my fellow human beings, I don't think that everybody shares that. And I think that that is part and parcel of our inability to reconcile that. We have compassion, in some people in our country have compassion for the people that they know, or who are within their family, or who like them, but they feel as though others who aren't in a privileged situation like they might find themselves, that they're there because of something that they did wrong in their life, or they made bad choices, or they're lazy. And that is kind of a philosophy or worldview is very difficult to turn that around, because it's really pretty strongly entrenched. And so why should I only want this much health care, and I don't want to pay for anything else that I personally don't have the potential of using.
Well, it's kind of like the argument that if I'm convinced that I'll never get into an accident, I should be made to have car insurance, right? And and then when I do go out and get into an accident, of course, other people bear the cost. I mean, even if one is completely an island unto themselves, there is an economic, self-serving argument for expanding the pool of coverage, right?
Well, and I think I mentioned a little bit of that earlier, where that while
I may not need maternity benefits any longer, thank goodness. But at one time I did, and I can see the benefit of continuing to contribute to that part of the healthcare system, because in the long run, having healthy mothers and healthy children and everybody sort of getting through that whole business in a safe way is beneficial to me, because eventually if they don't, I'm going to pay for it. You asked for one of the examples of the essential health benefits that they're, again, talking about, which of course is a women's health nurse practitioner, so it's in my heart, is contraception. And I'm talking about contraception, not abortion. Okay? It's a whole different issue. And so we did see a dramatic decrease in the number of unintended pregnancies, or if you want to look at it in a positive way, an increase in the number of intended pregnancies. Because, and the feeling is that directly related to the fact that contraception was first dollar coverage. And so men and women were able to then go to their healthcare provider if they had insurance and get contraception of their choice, and there's lots of choices, and learn how to use it effectively.
A member of the audience would like to ask, why did premiums go up? I know we've touched on this a little already, but is there a simple explanation for why premiums went up?
Well, at least from what I read, anyway, I'm not an actuary, and I don't work in the insurance company. I only send claims to them. But the feeling is that there was a overestimate on the part of the insurance company, and perhaps the people that designed the marketplace, and the number of people who would actually join it. They expected there would be a lot more people to enroll, and that there would be, and more of those would be younger persons and people who weren't going to use insurance. Again, that's spreading that cost of healthcare across a larger number of people, which is the way most insurance plans work, of any type. And that did not happen. And I think that the insurance companies themselves underestimated the cost of then taking care of a higher risk pool than they expected. And then were spending a lot more on taking care of people. And so they had to have, it was a market adjustment, which happens. And it was understood, at least in my circles in the healthcare industry, that was a one-time increase, but that was not very well publicized. The other thing is that the federal government, our tax money that's going from Arizona to Washington would come back to us in the form of increased subsidies, so that the actual increases for people who were at least in the marketplace would either, they would have no increase, or it would be a very small increase.
So the aforementioned low premium costs that we had in Arizona prior to the ACA, combined with the fact that so many of us are older than the average, American here in Arizona. It's a beautiful place to retire. Another question, the same person. Why only one provider in Arizona?
I think it gets back to this whole central issue of, if we have such a narrow number of people that are typically older, because if you're 26 and under, you're covered under your parents' employer plan, hopefully. So you have a narrow group of people that typically need more health services. They're likely going to use their health benefits more regularly, because they're not younger and healthier and only need it when a situation arises. That will drive up the cost. And there were no real protections on health plans being able to exit the exchanges. And I think so. We have to come back to this central point that we're all trying to make, that we have to really increase the pool so that we have somebody that's just born that's in the pool, and we have somebody that's in need of care that's at 75, 80 years old that's needing more services, and it's balanced out because of the individuals at a younger age are needing less. And so I think that's really the key, is that we allowed the health insurance plans to exit, because there were really no penalties for them to do so. And in large part, I think on a micro matter, the issue around people up to the age of 26, the younger generations really are covered under thankfully are covered under their parents' employers plan, but not having them in the exchanges really hurt the overall pool.
Since so much of what you're describing is, particular to Arizona, is there a role for local and state governments in sort of alleviating these circumstances, or do we have to wait for the national, the federal Congress to either repeal or replace or do the like?
I think we should insist upon Governor Ducey and our elected officials that we have a very good system. With a couple of tweaks, we could demand that, as I mentioned earlier, that we can take the 2.2 million people, take the 200,000 that benefit from the exchange, put them in a delivery system that already works, is much cheaper than the exchange, and deliver care for folks throughout the state so that in every county of this state, we would have a minimum of 2, if not 3, health plans. So there would be choice initially, there would be a larger pool, and there would be no reason why any of the current health plan providers that are delivering care on the Access Medicaid side, they would never want to leave that system. So it's just a matter of saying, hey, listen, let's help the 200,000 Arizonans that benefit from the exchange. Let's get them in this pool. I don't understand why an insurance company wouldn't propose that themselves and say, you're doing the right thing for our state, and you're reaching out, you're covering people that have a need, you're helping in rural areas. We're in a position now where some of our rural hospitals, if this, whatever you want to call it, Ryan Care tax cut plan went through, there were several rural hospitals. Kingman was threatening to close, other facilities in Mojave County. And what would have happened is you have a wreck up in that area, you end up either going to Flagstaff or being flown to Las Vegas or come to Phoenix. It would burden the rest of the system. It would really be kind of a race to the bottom as far as the system goes. So if I were a health care insurance company person, which I'm not, I would say, I'll look after those 200,000 people. In exchange, I'll provide a good Medicaid benefit plan as well, and then they pay into that system based on their income. They'd have health care protection, they'd have a network of providers already built, and we'd have choice and competition throughout the state. So to me, it's a no-brainer, but it's a matter, I think, of all of us looking at that and figuring out a way to push it, and then look long-term to a kind of a Medicare for all solution as far as I'm concerned.
Anyone else on state, local government solutions?
I mean, I do think for the marketplaces, other than it really does require some federal fixes like enforcing or maybe even increasing the individual mandate. Part of Arizona's too, I forgot, was just making that adjustment. I mean, when you're giving people insurance for the first time, there's pent-up need. There are health conditions that need to be remedied, and people are sort of learning health insurance literacy, learning the behaviors of accessing preventative care, to not let things spiral out of control. So some of it also is just adjustment that the market, needed to do, the insurance market, and our insurance market needed to adjust to be more in step with what was happening at the national level. And I think it was 77% of the people in our marketplace, in Arizona's marketplace, did get the cost share, of course, the premium tax credits that brought down their premium. So most people could get a plan for $75 to $100 a month, and then got the cost sharing subsidies as well. So that helps with all the out-of-pocket costs. So it wasn't as bleak, the increases as people made them out to be. But also you have to change, a pool of people. You have to give time for people to change their behaviors and give time for and also enforce that mandate, because like you said, it forced that risk pool of older, sicker folks. And we just couldn't talk those millennials into signing up, and plus some of them were covered through age 26, which is another sort of fix that I think should happen at the federal level. So there are some federal fixes if we're talking about the marketplace that do need to happen, but we can certainly pressure people like Ducey to advocate for them and not for the wrong thing.
The other side of this, one of our audience members asked, are there things that the current legislature here in Arizona might do to create a death spiral of the ACA? Are there bills we need to watch for in the future?
No, but I can talk about some stuff that the legislature's doing.
Please do.
Impact.
We won't let it get outside this room.
Well, one quick thing back to the federal that we haven't talked about, which is the CHIP reauthorization. So CHIP is the Children's Health Insurance Program. It's kids care in Arizona. We were the only state in the country not to have one until we brought it back last summer. And since then, thousands of kids have been enrolled, and it's great. But the CHIP program needs to be refunded. So we can talk to our congressional delegation about, hey, let's do a quick, clean, bipartisan reauthorization of this program and get a win, because most of them are not experiencing a win in healthcare right now. So folks like McSally, this could be a win for her. In terms of just doing a quick reauthorization of CHIP. But our legislature, so another thing is, creating barriers to coverage. So we have this great Medicaid program. It has super low fraud rate, which is not actually called fraud, but it means like 99% of the people who are in it should be in it. They didn't falsify anything. They're not, faking out the government. It's efficient. By the way, Medicaid has about half the administrative costs as a typical private insurance company. We've got this great insurance, and 2/3 of it is funded by the federal government, our tax dollars going out back to us. And it covers 2 million people. But our legislature, our state legislature, decided, well, we want to put some barriers on this coverage. So we are going to force our Medicaid agency Access to ask to augment its program. It's called the Section 1115 waiver, but it's basically asking to change the program to put work requirements on people. Almost 80% of the people on Medicaid already work, so I'm not sure what that's accomplishing. And to do lockout periods, 5-year lifetime limits, all these things that are proven to be barriers to coverage. And by the way, incredibly expensive. I mean, talking about adding those layers of red tape and bureaucracy, it's adding a ton of layers of red tape and bureaucracy. Why? And so our Access program applied for this. CMS shot it back and said, no, CMS regulates the Medicaid agency, and shot it back and said, this does not accomplish the point of this program, which is to provide health insurance. Now the administration has changed. Access had to reapply because the law, so it's SB 1092, was passed by our legislature, and they have to ask every year for these changes. Well, things changed in Washington. Now this amendment is very likely to be accepted. And we're going to see big inefficiencies introduced to our state Medicaid program. And that's what our legislatures have done, bogged up something that is functioning very well.
Okay. I was reading the other day that prior to the ACA, on average, women in this country paid 31% more in healthcare costs than men. Is there anything in the AHCA that you know of to address that? Do we return to that scenario if the ACA is repealed under current proposals? Does anyone know?
Yes, two different questions. The answer to the first question, if the American Health Care Act would return to those days? Yes. Did the Affordable Care Act fix that? Yes.
No joke. Okay, so no provisions.
Defunding Planned Parenthood, I don't see how that's going to help women's health at all.
Right.
I see that as a positive. But I could be bummed.
Anyone else? Okay, seems cut and dry from Dr. Ling's point of view. A question from the audience here. I heard Congressman David Schweikert say that 0.2% of his constituents here in Scottsdale, here in District 6, are on the ACA. Can you corroborate that?
I have that statistic at my desk. I don't think it's 0.2, but I can get whoever asked that question. The 5 congressional districts who's on what type of insurance, including the
well. You should never ask a question if you know the answer. Right? But this audience member does answer the question to say that in their view, it is 42,000 projected to lose coverage in this district, or 5.7%. That's about around the lines you were thinking. So.
Well, and Chris, that really speaks to the Medicaid and Medicaid expansion losses that would occur under the proposed plan. That there would be an elimination of the expansion, so from 100% of the federal poverty level to 138%, anyone that became eligible under Medicaid expansion would be eliminated from health coverage. And then individuals that are below 100%, there would be a per capita finance model that would be devastating, because the state would then be forced to figure out how to use a limited amount of funding to cover the population. So it would be very, very problematic. And I think in this particular district, that if Representative Schweikert is aware, I mean, we have numerous healthcare facilities that have benefited from Medicaid expansion, even the exchanges, and significant people would lose insurance in the district. I think that 42,000 number has been verified, as well as the number of healthcare jobs, the economic impact as well for systems. Number of facilities would have to close, either departments would have to close, potential hospitals, nursing facilities. Most of the Medicaid dollars goes to support people that are on long-term care. And those people could be impacted. And these are individuals that have serious medical issues, behavioral health issues, sometimes need to be in assisted living type of housing facilities that our Medicaid system covers and pays for. So we're unique that way. And it's working. So to kind of put that at risk for some ideological reasons seems foolish to me. I think it would be very harmful for the entire state, but specifically in this particular district, there would be a lot of healthcare jobs lost because of just the number of hospitals and health facilities that exist.
So that's actually something else I want to ask about, and that's the economic impact of potentially repealing Medicaid in the state. So jobs lost. What are the economic? I mean, how many federal dollars do we get in Arizona as a result of the Medicaid expansion, and what would the withdrawal of those dollars do to economy?
We commissioned the ASU WP Carey School of Business to take a look at that. So the $866 million that comes into the state from the per year for the marketplace, and the 3 point something billion dollars that comes in from, again, our taxpayers. We're paying federal taxes. They go to the federal government. They come back to us in the form of the federal share of Medicaid. They took those losses from a repeal scenario, and this is just the marketplace and Medicaid expansion. This is not the long-term cuts that would come to the entire Medicaid program. And they figured out that in the first year, we would lose 60,000 jobs, and half of them would be in healthcare, which, by the way, is a bummer of a sector to lose jobs in, because it is our strongest, it adds the most jobs, it's recession-proof. When our economy was losing jobs like crazy, healthcare was building jobs. The average wage a healthcare worker, and now of course there's a huge spectrum from brain surgeon to medical assistant or whatever, but the average healthcare job pays a higher wage. So these are good jobs. This is our fastest growing sector, and it's also a sector that is immune to, or not immune, but does well during recessions and downturns. And then it affects other jobs, right? So there's a ripple effect. Small businesses that provide supplies to a hospital center, or whatever it might be, or to doctors. And by the way, doctors are small businesses. So, that's another impact that we don't recognize. So it's really bad economically, but then also the population, the people that we're talking about on this expansion, they make up the backbone of our economy. So these are low wage, tend to be low wage workers to make that threshold. This is a retail worker, a food service worker, a construction worker. these are people that make up the backbone of our economy, but do not get health coverage through their jobs. And so they rely on this to make ends meet, you know, as well as, so as well as many of the folks who are on this program, obviously they're working in low-wage jobs, may not be able to maintain their jobs if they lost their health coverage because they have a chronic condition, which they're able to control thanks to medication, thanks to treatment, thanks to intervention through behavioral health, and can get up and take the bus and make it to that shift and serve, you know, us food or whatever it might be. But if they were to lose their Medicaid coverage, then would struggle to keep employment. And that becomes also a drain on our economy.
An audience member asks, is it true that part of the problem with the ACA and insurance companies being uncertain about their risk is that Congress never fully funded the ACA?
I think that there are parts of the ACA that are still being rolled out, and that is one of the areas where the threat is to the Affordable Care Act. If they can't repeal it, they'll just make sure that the finances are not appropriated to pay for some of the costs of covering people for their health care. I'm not sure that the act itself was underfunded. I think the primary issue was that the back to the risk pool problem, where the incentives were not there for people to enter the market, and I think that's where the problem lies, and that's definitely something that has to be fixed, you know. And rather than I like to take a positive approach to it rather than to be punitive and say that you're going to be punished if you don't enter the risk pool, to try to develop some sort of an incentive program that the people will say, yeah, I think that's a good idea. I think I'm going to buy into that and reward them for becoming a part of the pool.
There is one, so I think what that question is getting at is, so there were supposed to be payments, and I can't speak to this too in depth, but there were supposed to be payments to insurance companies to supplement or to help them out in exactly the scenario sort of that happened with the you know, older, sicker population, more expensive population entering the marketplace, and those payments were never refunded. And so that, and it actually goes back to why insurance companies were pulling out, because all of a sudden there wasn't this guarantee, or, you know, they didn't think that they didn't know if they were going to be covered on the back end, and so they didn't want to take the risk of entering the marketplace and offering insurance.
That leads me to another question from an audience member. What is preventing the remaining healthcare provider in Arizona from also withdrawing?
So
I don't like their response. I don't know about you. It doesn't make
that's the problem, I think, with the system, is that they can withdraw. They can decide not to provide that coverage any further, and they just have to alert, you know, CMS that they're not going to provide benefits in 2018. So there is that risk.
what would happen? Like, what would happen?
Well, the 200,000 people would really be in a terrible situation, because they wouldn't even have a health plan that they could choose from to get their health coverage. And you know, it's really coming back, you know, to what can we do as healthcare advocates and citizens to really ensure that we are dictating the terms of coverage, and that we have a tremendous say in what occurs and what happens. And finance folks have a tendency to look at things in kind of narrow buckets and say, okay, well, that bucket's not making money, so we got to cut it. And I think we need to make sure that they know that you can't just look at that one bucket. You have to look at all the other buckets that you're receiving federal funds, and that's on the Medicare side. They have no trouble being Medicare Advantage health plans. or Medicaid Advantage health plans. And so I think we are in a position with great leverage to say to our leaders, we need these plans to have services available for those 200,000 friends and families and neighbors and people living throughout the state. If you're going to do business in the state and you're going to receive state dollars, you're going to receive federal dollars, you also must provide an efficient, affordable health plan for individuals that are not covered in whether it's a group employer or through other means. And I think that's the piece that, to me, we need to push for, because it could happen in 2018.
It seems as if part of what's behind some of these questions is the sense that, you know, if you're a member of a political party that has been saying this law is about to implode, you don't really have a political incentive to stop it from imploding. And so I think I hear in a number of these questions the concern that we lack a kind of political force right now that is empowered to you know, actually reform the law, prevent, for instance, the last insurer from leaving Arizona and leaving 200,000 people without coverage.
Right. The other option would be let those 200,000 buy into Medicare. And that system is readily available. And, you know, it's easy. I'm not yet 65, but people tell me that when they go down and sign up for the Social Security office, it's the easiest process in the world. And so I think we could have that option available too, and to promote and push and advocate for that. If the remaining plans want to leave the marketplace and leave the 200,000 people in horrible position, then let's allow those individuals to buy into fee-for-service Medicare. And I think then we might get the insurance company's attention, because that's not what they want to have happen. Because that will open the door for the best solution, in my opinion, and get us all in that light. So I think that's the key.
It's okay to applaud.
We need to push for that. We need to hold the insurance, if they want to provide insurance and they're collecting a lot of federal and state dollars, they need to take care of our neighbors, the 200,000 of them that are needing care. And I think it would be their responsibility to do so. And they probably wouldn't want my solution being offered up, because long term that's not going to be in their best interest. So that's the way I would go.
We have another 10 minutes left, and I have some more questions to ask you from the audience. But just before continuing, I want to take this moment to make an ask of our audience. If you're finding this discussion productive and worthwhile, and you'd like to hear more about events like this that we will hold in Phoenix in the coming months and maybe years, concerning areas of concern to us all, such as climate change, immigration, the budget, tax policy, if you send a text right now, or I asked you to silence your phones, didn't I? I'm a rank amateur at this kind of thing. If you send a text at some point to our Call Hub account, and many thanks to our social technology working group for getting this going for us, especially Christy Love. The number is 480-725-5557. You send a text with anything at all in it to that account. We promise not to troll you, but we will let you know. We'll give you some basic information about our organization if you're not already a member. But we'll also, after that, just send you discreet, tasteful little announcements of events like this. But yeah, I'll repeat that, and I'll also repeat it later before we leave. But if you're sending a text now, it's 480-725-5557, and you'll get a couple of questions back, and then after that, you'll be ready to go. And I'll repeat that later on if you didn't quite catch it. But now I have a really great question that has to do with this, this issue of political incentives. Tomorrow evening, one of our members points out, we will have a chance to speak to Senator Flake at a town hall meeting. If you're not aware of that, Senator Flake is holding a town hall out in Mesa. You'll find the address all over Facebook. What can we ask him specifically about American healthcare that you think might make a difference?
Okay, so I just sent some questions out to our coalition members at Children's Action Alliance. So I think stick to the basics, which is, do you support a healthcare plan that kicks people off of coverage, that increases out-of-pocket costs for Arizonans, and that reduces the quality of care. Do you support reauthorizing the CHIP program, and when are you guys going to get around to it? What are some other questions?
Just back to the essential health benefits. Do you support a plan that provides a basic set of essential health benefits that have been demonstrated through research to really make a difference in the health status of people, and not cherry pick, what you're going to pay to let these insurance companies who are going to participate in some whatever comes out of the healthcare reform, just offer a plan that really, when it comes down to it, it doesn't really have any kind of an impact on people's overall health status. It doesn't improve the health status. It doesn't promote and incentivize people to participate in preventive health care. That's a long question. But really, basically, are you going to support health plans that the authorization of health plans in whatever this program that comes out of this that are going to truly provide health care?
Yeah, I've been hearing everybody talk now. Is why not Medicare now for all of us in this room? I mean, why not?
Just strike the phrase 65 and over.
Yeah, why not? Are we going to wait another 20 years, another 30 years? And this came up in our last conversation. The policies we set into place now, we may never see, but our grandkids and our children may benefit from those. And that's what it's all about. We hope we get to see some of the benefits. But again, I'm almost 62, and all I've heard about probably for the last 40 years is Medicare is always in trouble. Social Security is always in trouble. But we find a way to take care of it. And I think that's where we're at now, is like, how can we try to bring other health plans into place or health ideas when we can't even get Medicare? Medicare seems to be our best bet right now. Why are we not building on that model?
Another audience member asked, and possibly the answers are similar, that he or she is meeting with David Schweikert next week. Yeah, great. What would you ask him about healthcare? Similar questions, or would you have something different for the congressman who is proposing high-risk pools?
Well, I would ask him, could he demonstrate where there has been proof that the high-risk pools have been successful? I've had no history or no examples where they've worked, and I think it gets back to the central question of, do you believe that healthcare is a right that everyone should be eligible for? And should healthcare disease or illnesses be one of the largest contributors prior to the Affordable Care Act, contributing to individuals' financial ruin and bankruptcy? So that's a big area that we didn't touch on, at least at the beginning here, is that the Affordable Care Act has significantly reduced the amount of federal or filings of bankruptcy because of healthcare related expenses. And that's a big piece that with the Ryan Care Plan, we were going to be heading for people not getting care because they couldn't afford it, as well as buying plans that really don't cover anything. And that existed in the past, where people thought they had health insurance, but the health insurance plan said, well, we don't cover emergency care. We don't cover prescriptions. We don't cover if you need to go into the hospital. So it wasn't clear what they were covering. And so I think that's a big part of the Affordable Care Act, is with the essential benefits, hospitals are interdependent upon one another as far as the services they offer. So we need all of those essential benefits to help health systems be able to provide care, maternity care, emergency care, behavioral health care, these things don't operate in silos often. They all work together, and so we need everyone pitching in and making all those pieces work. So that would be the big piece for me with Schweikert is, do you believe that healthcare is a right and that it's been a big contributor to helping people avoid bankruptcy?
I have two more questions just before we call it an evening. One of our viewers from across the valley who's watching this as a live stream has a question about Marco Rubio. Is it true that Marco Rubio was a key factor in the sort of the devolution of the ACA in ways that sort of affected its ability to fund itself? With the risk corridors, okay. Could someone with a mic repeat that?
The issue was about Senator Rubio and his actions and how it really helped to destabilize certainly the exchanges, and it relates back to folks that have higher expenses. The insurance companies were told that they were going to receive some additional funds based on the health status and the health utilization of the individuals on the exchange. And he helped kind of prevent those funds from flowing to the health plans. And that's been a big reason why a number of the plans have decided they were going to exit the market.
We need to vacate the room soon, but before we do that, there's another question here that I think is a great one. Where do you get your information? Not your professional journals and so on, but where should we be getting our information about matters that we've been discussing tonight? There's some good outlets for information on healthcare in Arizona.
I think one of the best ones that I've found that's the most balanced is Kaiser Health Fund. Kaiser Health Fund.
Kaiser Health.
Commonwealth Fund is another good resource.
There's
What was that second one?
Commonwealth Fund.
Commonwealth Fund.
It's nonpartisan, apolitical. It's just straight talk.
Yeah, they're great. I agree.
There's a journal that you have to subscribe to, but Health Affairs often has a lot of information as it relates to health utilization, health spending. There's a Princeton economist that I saw last week up in Seattle for a conference. His name is Uwe Reinhardt, and he's done a lot of analysis on the significant expenses that we're paying in our country for administering healthcare and how we can really eliminate some of those costs and put them into delivering care, and get the dollar closer to the provider rather than going through machinations of administrative expense and so forth. So he was he's a Princeton economist. If you Google him, he's got a lot of good information as well.
I would say the American Nurses Association, if I can put in a plug for my profession, people tend to think of us as, oh, you're just a bunch of Democrats, you always know that. But the fact of the matter is that happens, and we seem to support more of a progressive agenda because of the nature of what we do and what we stand for, which is, the patient. Always the patient first. And the Nurses Association, you don't have to be a member to access a lot of the information and position papers that they have out there about healthcare in general, and that's pretty much what you'll find there. It tends to be, they try to be as unbiased as they possibly can and fair, but you'll find that most of the time that they're going to come down on the side of the patient. I'll do a shameless plug. So if you don't want to read through all the Center on Budget and Policy, Priority, Urban Institute, Kaiser, and all of those, you could go to our website because it's like my full-time job to synthesize all that health policy information and to create fact sheets. And so if you go to azchildren.org and search for health stuff, or you can even just email me and I'm happy to send you
I'm currently working on a Medicaid fact sheet and a kids care fact sheet, but we have a couple fact sheets already on the American Health Care Act and economic impact, all the stuff we've talked about, and it's all sourced. So if something interests you, then you can just go down to the footnotes and then access the actual source information and learn more.
And I've been passed a note that says that Andy Slavitt, who oversaw the ACA for Obama plus Medicaid, is also another good source. Thank you. Okay. I could go on for a long time. This is the kind of discussion I love. I just want to remind you all one more time, if you're interested in more news on events like this, please send a text to 480-725-5557. That's our call hub account. But more importantly than that, at this point, please join me in thanking our esteemed panel for their expertise tonight. Thank you so much, Michael Bowman, Mike Rosa, and Denise Lane. Thank you all. It is Congressional Recess Week. Please be calling your members of Congress. And once again, a Flake Town Hall tomorrow evening in Mason. Oh, and I'm Chris Hamlin of AZ CD6.